so they restore the immune balance. But naltrexone, I know it does shift from Th1 to Th2, and I think it's very good for patients with addiction, because patients with addiction with too much of narcotics, and narcotics do stimulate the immune receptors, which generate free radicals, and I know those free radicals do shift the immune system to Th1, and it definitely helped patients with drug addiction as well, not just naltrexone.
Yeah, well, we're
And
talking
the side
about
effects of the narcotics, which is this free radical generations of the brain, which leads to neuroplastic changes of the brain, and that leads to what we call it allodynia and hyperzenia. I think we talked about it when we talked about central pain. So we really need to know about what is Th1, Th2 dominant, Th17, Tregs. This is the new language that we need to integrate in our practice and understand it, because it gives us a better understanding of how, or the pathophysiology of the disease, and how to modulate the immune system instead of suppressing it using steroids. So most of the time when we have inflammatory diseases or autoimmune, we just give steroids and cortisone, suppress the whole immune system, and that will put the patient on risk of having cancer infection. I think instead of suppressing the immune system, we figure out what is the immune status of the patient, where is the immune system is moving to. Is it Th1 dominant, Th2 dominant, Th17 dominant, and how we can modulate it, shift it without suppressing the whole thing. And I think this will minimize the side effects of risking the patients developing cancer and infection. And so let's go ahead and understand how the immune system works. I think before our understanding of the immune system, we have innate immune system, which really fights everything that's foreign, and differential, not specific, natural killer cells, macrophages, neutrophils. And then we know that the immune system also has something called acquired immunity, where they specifically attack certain pathogens. So they are more specific than innate immunity. The reality, they don't work independent. They work in connection. They work in a team. And we're going to see that team and how they work together and how they coordinate each other. So let's start with saying that the patients are encountering bacteria infection. So what will happen here? The macrophages will eat that bacteria and taste that bacteria and start secreting interleukin-6, which will polarize the naive T cells into Th17. And then the Th17 will start stimulating the neutrophil proliferation, differentiation from the bone marrow, and you will have what we call neutrophilia. And this is how the body do attack the bacteria or the fungus, for example. And yes, you would have some sort of Th2 going on, some antibodies going on, yes, as well when you have bacteria infection, but mainly you will see neutrophilia is the main immune defense against the bacteria, plus antibodies from Th2. And so when you see neutrophilia in patient who has been, you see the CBC differential and you see neutrophilia, you think, oh, this patient may have bacteria or fungus. You start investigating, doing your blood culture, doing your, and trying to seek where's the source of the infection. But if the patient encounter cancer or in virusly infected cells, virus infection, then the macrophage will eat those infected cells with virus or eat those cancer cells, taste it well, and then present it to the naive T cells and start secreting interferon gamma and interleukin-12, which will polarize the immune system into Th1. And then Th1 will start stimulating cytotoxic T cells, because the way we can fight cancer-infected cells with viruses is having cytotoxic T cells in direct combat with those cancer cells, attaching those cancer cells. So the major histocompatibility complex and secreting what we call cytotoxins and blow those cancer up, and also attaching those infected cells with viruses and secreting cytotoxins and blow those cancers. So you cannot fight infected cells with viruses or cancer effectively with neutrophils. You really need cytotoxic T cells, and you need them to attack those cancers and viral infected cells and destroy them. So neutrophil will not do it, basophil will not do it. You need cytotoxic T cells. So you need Th1 and moving your immune system to Th1 direction. And so when you do the CBC differential and you see lymphocytosis, you think, okay, this patient may have cancer infection, but let's investigate and find out if the patient has cancer infection. So you start digging more, doing lab to find out which one it is. Okay, now, if the patient encounter allergens or warm parasites, then the macrophages will eat those, taste them, present it to the naive T cells, and they will start polarizing the immune system to Th2, and then Th2 will start secreting interleukin-4, of course, and interleukin-4 will stimulate the mast cells. Mast cells start generating immunoglobulin E, and then immunoglobulin E will start attacking those parasites or those allergens. And also, among that, interleukin-4 will stimulate differentiation of the white blood cells to become basophil, eosinophil. So what you will see basophilia, you see mast cells and activating, and you will see, and that's how your immune system is fighting allergen and parasites. Okay, so if your body starts certain way, your macrophages start eating your self-antigens, then those macrophages will start secreting interleukin-10, transforming growth factor beta, and that will polarize the immune system into Tregs, and Tregs will suppress all the immune system that is self-attacking. So this is how we prevent the immune system from attacking your own cells by the Tregs. So Tregs secrete interleukin-4, which will inhibit all the effector cells, T cells, whether it's Th1 or Th2 or Th17. So and now we understand that the innate immune system and the acquired immune system, they work together in a coordination. And now we understood also that in order to fight cancer and viral, you need cytotoxic T lymphocytes. You need Th1. If you want to fight bacteria or fungus, you need Th17 and neutrophil. If you want to fight allergens and parasites, you need Th2 and basophils and mast cells, right? And immunoglobulin E. So this is how the immune system works. But is there any exceptions? And then biology, we know we don't have a strict rule. There are some exceptions happening. And exception is what we see in COVID-19 virus. If we see the COVID-19, it's a virus, and we're supposed to see lymphocytosis. The reality is that we did not see lymphocytosis, we saw neutrophilia. To the point that people think, oh, this is maybe secondary bacterial infection. No, the virus itself is fooling the immune system and is polarizing the immune system in the wrong direction. It's polarizing the immune system into Th17 instead of Th1. So it's fooling the immune system because normally the macrophage, when they eat this virus, any virus, especially the cells that's being infected with virus, and we call intracellular pathogens, they're supposed to be polarizing into Th1. You see lymphocytosis. But this COVID virus is different because it's man-made. It's been engineered. And the way that it will fool the immune system, polarize the immune system in the wrong direction, which is Th17. And now that happened, why this protein or this COVID virus is different from flu virus. If you have flu virus, then the polarization of the immune system will be Th1. You see lymphocytosis. Yes, but COVID is moving the immune system to Th17. So why? Because they have the spike protein man-made, engineered. And those spike protein hijack the renin-angiotensin system. And when they hijack the renin-angiotensin system and they block the ACE2 receptor, which is the anti-inflammatory arm of the RAS system, then you have unleashed inflammatory arm of the renin-angiotensin system, which is angiotensin 2 type 1 receptor is active. And down the cascade of this receptor, which is type 1 receptor, which is overactive, it leads to production of interleukin 6 and polarization of the immune system to Th17. So because of that, because of the hijacking, it leads to, instead of polarization of the immune system to Th1, it polarized the immune system to Th2, and so you have neutrophilia, and doctors, they think, oh, this is because of secondary infection. No, this is because of the virus itself. Of course, if doing that, this will cripple the immune system, because in order to fight COVID, in order to fight infected cells with viruses, you need cytotoxic T cells. You need cytotoxic T cells attacking those infected viral cells and secreting cytotoxics to blow them. You cannot fight infected cells or clear viruses from infected cells with virus with neutrophils. That's not the army that, it's like chess, okay, playing chess, exactly, right? You need to have the queen to destroy those infected cells with viruses. And so that's the reason why, in order to manage COVID-19, we need to do two things. We need to block the angiotensin 2 type 1 receptor, that's one thing, to prevent that polarization or to prevent that cascade of signaling that leads to, in the beginning, interleukin 6 overproduction in Th17. And also, we need to polarize the immune system. Yes, doing that will polarize the immune system to Th1. So losartan will be a good thing to do. And then thymosin alpha also will help to polarize the immune system to Th1. So anything that helps to restore and polarize the immune system to Th1, like thymosin alpha, Methylene blue, ivermectin, all of this helps to polarize the immune system to Th1. So they are good in managing COVID-19. So COVID-19 viruses is not just regular viruses that we encounter. It's more of causing immune dysregulation or wrong immune response.
Dr. Halasa. Dr. Halasa?
Yes, go ahead.
Question. So do you think that this, when you mention about that you have to encourage the polarization to Th1, so that means what about when they vaccinate and they have adverse reaction? Within what period of time they can use this agent, whether it be losartan or TA1 or methylene blue, to polarize to Th1, because they have acute response with the cytokine excess. I wouldn't call storm initially from the vaccine.
Right. So let's go to the history. Even when you are before, when we have the flu vaccines, and those flu vaccine, yes, they polarize the immune system to Th1, but to ensure more polarization of Th1 and enhance the immune system against the flu vaccine or flu virus infection, they add thymosin alpha up to 2 weeks. So after 2 weeks of the vaccination of flu virus, there's an article, good publications, they adding thymosin alpha. I will share with you that. So although flu vaccine is not like COVID vaccine because they don't have a spike receptor that will trigger the whole thing back to Th17. But to just enhance it, they add thymosin alpha up to 2 weeks. And I will send you that article. I think that would help to enhance the immune system and making sure that they are polarizing into Th1 and you have enough of memories of cytotoxic T cells in Th1. And that's very important. The reason why, because all those people who are making vaccines, they are judging their efficacy and approving its efficacy, like they say it's effective, and 90% is based on that antibody titers. But that antibody titers does not give me a real answer for the immune. They don't give me the correct immune that we need to fight the COVID virus. You need cytotoxic T cells and Th1 memories, not plasma cells or Th antibodies and Th2 memories. So what they're seeing is they're seeing antibodies high. Yes, that's mean you have a lot of Th2 memory cells, possibly some of, but that's not antibodies will not be enough or cannot really clear and destroy infected cells with viruses. You need cytotoxic T cells. And that's where I think that those vaccines, they need to be reevaluated and check their memories of cytotoxic T cells and Th1 and approve the vaccine based on the memory of Th1, not the antibodies. But people who are in the head, or I think people who are making those decisions, I don't think they're immunologists. I don't think so. I doubt it, because if they are immunologists, then when those doctors are reporting that when they do the second vaccine, they see neutrophilia and they see the CD4, CD8 ratio increase, which means that you have too much CD4 instead of CD8, then this vaccine is not working. It's not working. That means that's not giving you the cytotoxic and Th1 immune response that we need to fight the virus, which means the virus can infect those people who are being vaccinated, and they can replicate inside the cells of the salivary glands, and those antibodies cannot really destroy them. And if they have any stress or they have any underlying immune system, underlying disease that suppress the immune system, they don't sleep at night or whatever, and their immune system drops, they will have the cytokine storm and they end up in the hospital. And as you see here, all this vaccine is not that, I'm not happy with the performance of it, because I can still see the spike of increase of the rate of infections similar to the last year. If you count the death of October of this year and October of last year, according to CDC, it's the same. Although almost 50% of the world population is being vaccinated. So there's a problem with the vaccine. Not I am anti-vaccine. I think we need to fix the vaccine. We're looking for better vaccine where we see more of Th1 memories. And there's one lab there. It's called, I think it's called T-Detect, something T cells or thdetect.com. It's a company who detects the memories of cytotoxic T cells. And that's how we can know whether the immune system is working or not. So the Fauci and his group, they say, well, you know what? We checked the antibodies of people who are naturally infected, and after 6 months, it drops, okay? Then natural infections were not providing us any immunity, so let's go ahead and give the vaccine. So that's the wrong premises. The reason why, because you don't check the antibodies, you check the cytotoxic T cells. And the reality is that after they made the studies, they find out people who are being naturally infected, they have more immune support or immune defense against the COVID-19 than the people with the vaccine. And it seems like the natural infection is not giving you much of antibodies there of memories and Th2, it's giving more cytotoxic Th1. And that's why the immune system that's coming up from natural infection is way better than is coming up from the vaccine. Because I think they are getting more of Th2 and Th17 memories. It's because of the spike protein works the same way like the virus, is polarizing the immune system away from the Th1. So what will be the solution here for the vaccine? They need to add thymosin alpha in their vaccine, possibly adding losartan, possibly because of spikes activates the platelets. They may need to add some heparin inside the vaccine itself. So we can cover all the side effects that the spike does, or if there is any other components of the virus, not the spike, to be the way that we can get the immunogenicity, that would be nice. But the spike itself, they're using the spike, which is being engineered by man-made, is the reason why the immune system is polarizing the wrong direction. It's the reason why we have platelets activation and stroke. It's the reason why we have the myocarditis, because this is damaging the endothelial cells and it's causing vasculitis. It triggers the autoimmune diseases as well. So we need to really look at the way to make the spike maybe immunogenic and less pathogenic, but not just putting the spike as it is. And yes, that's the problem where the vaccine development is not easy thing. 1 year of developing vaccine is not enough, because you need to figure out all those problems and start solving it. It may take another 3 to 5 years. Another thing, recently they start doing intranasal delivery, which I prefer than intramuscular, because intranasal, yes, when you do intranasal, then you get immunoglobulin A, and the memories for the immunoglobulin A production in the mucus, which helps a lot to prevent those viruses from getting in the beginning. So if you check the immunoglobulin A level for people who are vaccinated intramuscular injections, it's low. So their mucus is not being protected. So even changing delivery, using intranasal. So if those kids, they are now doing the immune for them, if they can try to make it intranasal, I think it's more better than the IV. But let's go with here. So we understand that the immune system, there is kind of a structure there that we need to learn about it. And there's a company, a new lab, I think. Well, it's an old lab, but they start developing. It's called Cyrex. But they start developing something called lymphocyte mapping. Okay, so before they do cytokine profile, just recently, this is just 1 year, they start doing lymphocyte mapping. What is lymphocyte mapping? It's not just measuring the cytokines, interleukins 10 and 12 and 4 and 17, which is responsible for polarization of the immune system, and the ratio, and the CD4 CD8 ratio. This is an old school. They're in the new school now. They are able to detect even the absolute number of Th17 and Th1 and Treg and Th4. So that's a good thing. So now we can have their numbers. They use some sort of antibodies that will detect the surface CD4 or CD receptors on those lymphocytes. So now, like we have CBC differential, and we are able to know the percentage of the basophil, eosinophil, neutrophil, lymphocytes, and now we can know lymphocytes and differential, or we call lymphocytes and mapping, lymphocyte mapping, where you can know the percentage of the Th17, Th2, Th1, and Tregs. We can now count them. Same thing like CBC differential, we can do lymphocyte differential or lymphocyte mapping. And so it's very important because before, the community of who was doing peptides, they're shooting in the dark. You know, they say, oh, we use thymosin alpha for this disease and thymosin beta for this. This is shooting in the dark, really, because before you shoot any peptides, those peptides polarize the immune system, by the way. You need to know what is the immune status of that patient. Is he Th1 dominant? Is he Th17? Is he Th2? And then based on that, you choose which peptide will be good for this disease. Like multiple sclerosis is Th1, Th17 dominant. I will give thymosin alpha because that will polarize the immune system from Th1, Th17 to Th2, Treg. If I have a Th2 dominant disease, including cancer, allergies, and systemic sclerosis, some of them, they are Th2 dominant. I will give thymosin alpha here to polarize the immune system to Th1, Th17. So when you have Th1, Th17 dominant, like rheumatoid arthritis, I will be polarizing the immune system to Treg, Th2, and I will use thymosin beta for that. If I have Th2 dominant, autoimmune disease or inflammatory or cancer, all of them are Th2 dominant and Th17 dominant. I will be polarizing immune system back to Th1, Treg using thymosin alpha. In COVID disease, it's Th2, Th17 dominant. So I will go ahead and use thymosin alpha for that disease. So if you hear that before, we think that the immune system, it's all about Th1 and Th2. Now that's not the case. We find out there's another thing, it's called Th17. And how we find that, we found that by trying to manage multiple sclerosis. Before, we thought multiple sclerosis is a Th1 dominant disease. And we developed antibodies, blockade of interferon gamma. We gave it to those patients, and we expect this is it. This is the medical, it's the treatment, because if you block the interferon gamma, you block the polarization of Th1 and you reverse it back to Th2. So when they did that, the patient got even worse. And the reason they find out it's not just Th1 in multiple sclerosis, it's Th17. So when you block the interferon gamma, Th17 start to flourish, and you have too much of response of Th17 to interleukin-6 neutrophilia, and that's causing the demyelination and damaging and destruction. So in multiple sclerosis, now we know it's not anymore Th1 dominant, it's also Th1, Th17 dominant immune diseases. Now, generally speaking, yes, when the immune system is moving to one direction, let's say they're fighting the virus, normally they start moving to Th1, and they see all the interferon gamma and interleukin-12, they will inhibit all other polarizations of the immune system to all other subsets. Or if you encounter allergens, you will have Th2 dominant, they start secreting interleukin-4, and interleukin-4 will inhibit Th2 and Th17 and Treg. So that's what we learn, and that's true. There is some sort of opposing each other in a way that helps the immune system to move to the direction that we need, right? So we need to move to Th1 to fight the cancer. So we need to, so interferon gamma is supposed to inhibit all the other subsets of polarization, everything Treg, Th4, and Th17. So that helps to move the naive T cells to that direction. We call this T helper in opposition. So you see that they are antagonizing each other to maintain or to keep the polarization to the immune system to the direction that we need to fight whatever pathogens is attacking the body. Okay, so that's the old school that we know that we classify the immune system, the immunological diseases as Th1, Th2 dominant. So if you want to manage Th1 dominant disease, we give them cytokines of the Th2. So we give them interleukin-4 to polarize the immune system away from Th1. If you have Th2 dominant, we give them cytokines of the Th1 to polarize the immune system back to Th. Like if you want to treat allergies, we give them interferon gamma, or we give them thymosin alpha to polarize the immune system back to Th1. So that's how we get allergy. That's what I did in Baylor College with Dr. Frank Arson. What he was doing, he's trying to figure out how we can manage allergies without suppressing the immune system. And so he said, well, allergies is Th2 dominant, so why we don't just go ahead and polarize the immune system to Th1? Okay, so let's say the patient has allergy to pennants or to pollens, right? Well, they encounter the antigens, the macrophage eats the antigens, extracellular antigens, and that would lead to polarization immune system to Th2 and start activating the plasma cells and mast cells and basophils and eosinophils, and that's secreting also immunoglobulin and give you that response of allergies, right? By histamine. And histamine also activates the Th2, and you have this vicious circle of allergic reactions. Okay, so in Baylor College, we thought, okay, if the macrophage eats extracellular allergens, the polarization will be to Th2. But if I have intracellular allergens that is expressing the genes of the allergens, and I develop, for example, a DNA plasmid that express the other genes like Collins allergens or Pennant's allergens. And so the macrophage eats the DNA segments, right? And that express intracellular allergens. Then these macrophages, right, they will be considered this as intracellular pathogens, And the response here is not going to be too dark to Th1. They start polarizing the immune system to not to Th2. They will start polarizing the immune system to Th1. And that's what we need to desensitize the body. So we start giving and feeding those macrophages with allergen plasmids. You can inject them subcutaneously, those plasmids of bacteria that express allergens. And the dendritic cells in the skin, macrophages, they start polarizing themselves. They polarize those macrophages into M2, into M1, and they start polarizing the immune system to Th1, and that helps to shift the immune system to Th1, and this will help to treat allergy. So you would have a lot of cytotoxic T cells and Th1 memories that secretes interferon gamma and interleukin 12 that will inhibit the polarization to Th2. So when you encounter the allergens, you will have enough of immune balance, enough of memory of cytotoxic T cells or Th1 that will secrete interferon gamma that will inhibit the polarization to Th2. And this is how we treat allergens, by modulation of the immune response from Th2 to Th1. And that's where the whole idea came from, using the RNA vaccines, because they say, well, you know, if we give the protein of the virus and we feed it the protein itself to the macrophages, you will see the macrophages may be polarizing to Th2 and producing you too much of antibodies. We don't want that. We want cytotoxic T cells and Th1 to fight intracellular virus and cells being infected with virus. So that's the reason our vaccine is not protein. And if you want to do protein, then you have to add interferon and thymosin to help to polarize the immune system Th1. But it's better if we construct the DNA of that viral protein as RNA vaccine, what we're doing. And then the pathogen will take it, and it's supposed to be polarizing the immune system to Th1. And that's how we can create a vaccine that's effective against virus, because we need a Th1 and cytotoxic T cells. Well,
yes. Go ahead.
Go ahead.
Sorry to break you right in the middle.
So if
okay,
you have any questions,
okay, I have two quickies. One is almost embarrassing because Th2, those are B cells, correct?
Yes.
Okay.
They are not the B cell. The B cells that will proliferate. They will work on B cells, differentiate them into plasma cells.
So right. The Th2 cells are not B cells; they are T cells.
They are lymphocyte cells, but we call them B cells. And T helper 2 do stimulate the B cells to become plasma cells, to secrete antibodies.
Okay. So it's in that line, but I mean it's in that
yes, it's the antibody.
The order of events is leading, but they are not actually B cells themselves. Okay.
I'm not sure. I think no. I think they are. It's like
T helper cell.
Inside of what is that?
It's T helper cells. Type 2.
So we have T helper cells, and then we have B cells. Yes. And then we have Th1 cells, and we have cytotoxic T cells, and they are different.
So Th1 is a T helper cell. So when CD4 is a naive cell, and that CD4 under the influences of the different cytokine will be converted into either Th1 or Th2 or Treg or Th17. So that's where the priming occurs. And then under the different cytokines they secrete, they have a different effect. And then Th2 can also have interaction with the B cells and the production of the increase in the B cell function. So similarly, they can have a function with the IgE mediated immunity. So that goes onto the different arms. But these are the 4 primary arms. When the CD4 naive CD4 gets polarized.
Right.
Perfect.
So
perfect.
Th1 is not cytotoxic T cells. Th1 is CD4 positive cells.
Right.
Cytotoxic T cells, CD8.
Correct.
So it's a different even class of lymphocytes. But all the other Th1, Th2, Th17, Tregs, they're all CD4.
And the Th1 is activating the production of
they are active. They are
stimulating
the
cytotoxic T cells.
Cytotoxic T cells, and the Th2 is stimulating the B cells to become plasma cells and producing antibodies.
But the T helper.
Right. Go ahead.
The Th1 cells do not turn into cytotoxic T cells.
No.
They activate something else to turn into a cytotoxic T cell.
CD8 cells, naive CD8 cells to become cytotoxic T cells. Yes.
Perfect. Thank you.
Right. Okay. So, and if you see here, they are opposing each other, as you see it very clearly, that if they polarize in one direction, their cytokines that they secrete will inhibit all other polarization. This is very important because if I find bacteria, I need more of neutrophil, so I need more of Th17. Again, you would never see a response purely Th1, like, okay, there's no others. You would have all others components, but mainly it will be Th1. Or if you have Th17, it's not just Th17, you have others, yes, but mainly, and more than 70% is going to be Th17. The rest is going to be, for example, Th2. Now, one will ask, okay, so if you have the Th1 stimulating the B cells and become plasma and developing interleukin E, antibodies, immunoglobulin E, what about immunoglobulin G and M? This changes and directing the antibodies subtypes or class. It's really depend on other factors, including Th17. So if you have Th17 is active in interleukin 6 plus Th2 cytokines, they can differentiate more into IgG. So the IgG-GM, in the state of becoming IgE, they become IgG. So there is a lot of interactions that will happen between the cytokines of Th17 and Th2 to shift the antibodies to immunoglobulin G. If you have too much of Th2, then less of Th17, then you will have going more into immunoglobulin E. That's allergens and parasites. But in bacteria infection, you will see also Th2 is active because you need it, because you need to produce antibodies. And then the cytokines of Th17 would help to make sure they will become IgG, not IgE. So those are another topic of influencing and classifications of those immunoglobulins, but they are all influenced by what the macrophage is eating and the type of the immune polarization and which one is the most dominant in the equation of fighting those pathogens. Again, in biology, we have the rule that, they are negating each other. That's true, but also there's something that's called neuroplasticity. Immune plasticity. Yeah, we have neuroplasticity. We talked about central pain, but also in the immune system they have something called immune plasticity. And what is immune plasticity? Is that if we go back to multiple sclerosis, and we thought it's only Th1 dominant disease. That's what we thought. But now we find out it's not just Th1, but also it's Th17 and Th1 both. And too much of Th1, maybe Th1 is more dominant than Th17 in the multiple sclerosis, where the interferon is too much, is being secreted. They can turn, instead of inhibiting Th17, they turn the Th17 into becoming Th1. So too much of interferon gamma from the Th1 cytokines and macrophage M1 and Th1, it can polarize those Th17 to become Th1. And this is called immune plasticity. And this is called Th17 Th1. It's a hybrid between Th1 Th17. And when you see this hybrid of cells, that's mean the prognosis of the multiple sclerosis of this patient is bad, because those hybrid, they cannot be suppressed by Tregs, interleukin-10. And they start eating or stimulating and secreting all the cytokines that will eventually stimulate the cytotoxic T cells and destroy the myelin sheaths and speed the progress of the multisclerosis. So we need to figure out how we can manage and polarize the immune system away from Th1 and also away from Th17, going to Tregs and Th2. Thymosin beta is a good answer. I think Dr. Patel has good experience using thymosin beta here in those cases. What other things? Anything that polarizes Th1 to Th2, naltrexone, low dose, which is Dr. William is going to be presenting it in Dallas. It helps those patients with multiple sclerosis because it does polarize more of Th1 to Th2. Methylene blue is good. Ivermectin, no. Well, ivermectin here, it mainly polarized Th2 to Th1, so I will not give patients ivermectin in this case. Now, again, we need to figure out some of the drugs, like polyphenols, okay, and like methylene blue, okay, they can polarize the immune system to both directions. It depends on which one is dominant. So if you have multiple sclerosis, you have too much of Th1, those polyphenols, because they buffer the redox, they polarize the immune system back into Th2. And if you have too much of Th2, those polyphenols buffer the redox, decrease the free radicals, and move the Th2 back to Th1. So it's restoring the balance of the immune system. I don't know about low dose naltrexone does that, but I know that naltrexone is very good at shifting Th1 to Th2. I know methylene blue.
In multiple sclerosis, Dr. Halasa, in multiple sclerosis, LDN has been used and has been found effective. So on a long-term basis.
Thymosin beta, you mean?
Low dose naltrexone.
Yes, because it shifted Th1 to Th2, and it's well documented.
Right. And as we know that in multiple sclerosis, the initiating factor is Th17 and perpetuating factor is Th1. So once it is very well established and demyelination is going on and causing a lot of defects depending upon the motor system or depending upon the sensory system. So these patients can be helped by giving something that would polarize Th1 to Th2, which is very neuroprotective. And irrespective of whether, so whenever there is a problem with the neurological symptoms, you may want to use the thymosin beta.
Right.
500, or it is also called TB500.
Exactly.
So,
okay, and just to understand why multiple sclerosis, for example, would be combination of a Th17, Th1. Does it have anything to do with one of the case presentations, actually, Dr. Patel did at the environmental medicine, excellent case, where the initial inciting factor is Lyme disease, and that's an extracellular infection that moves into an intracellular infection. And so you have the initial Th17 reaction, which is an extracellular pathogen reaction. And then as, say, for example, if the Lyme, the Borrelia, if it moves into the neuron intracellular space, then it's triggering Th1. And so the combination of those chronic responses and release of those cytokines and passing through the blood-brain barrier, those different types, neutrophils and cytotoxic T cells, is causing the the demyelination. Is that kind of in the ballpark?
Right, that's where you have
Well,
you stuck to the grid.
I would not consider that cytotoxic T cells is causing demyelination. It is the inflammatory changes that eventually leads to the neuroglial inflammation. And then the involution occurs, and then we have to oligodendrocyte. We have to activate so that they would myelinate the tissue. And I showed a lot of different slides that how that occurs.
Right, let me go to those people in the there's glitches here. Yes, when you have, okay, it's a bacterial infection, okay? And normally when you have a bacterial infection, we move to Th17. That's true, but this bacteria is also intracellular bacteria infection.
That's right.
So it does have extracellular, it does have intracellular, and it does infect the blood vessels, endothelium of the vasculature of the brain. And that's how it triggered the neurogliosis and possibly trigger some autoimmune and leads to demyelination. In this case, I will go ahead with the priority here. Is now priority for me is to decrease the inflammation, decrease the demyelination, or is my priority is to kill the bug? Right now, my priority is really to stop the progression of demyelination, inflammation, which is mediated by Th17, Th1. So I will be giving thymosin beta to polarize the immune system, yes, to Treg and Th2. Although this may cause the bacteria to flourish because now you're giving them something to suppress what's eating them. Then I will give them methylene blue, antibiotics, photodynamic, and try to destroy it that way, the bug, while I am moving the immune system away from. Because here is the glitches where you have two is moving to opposite direction. I need Th1, T17 to destroy the bacteria, yes, but destroying the bacteria means destroying the myelin sheaths. Who is the priority now? Is to stop the degeneration of myelin sheaths and destruction of myelin sheaths or destroying the bacteria. I think stopping the demyelination is first, and then looking for other way to kill the bacteria using platelets, nanoparticle, loaded with antibiotics, loaded with methylene blue, stick it into those bacteria and blow them up with other way.
Dr. Halasa, first thing is that the causation is the spirochete. And so we know that Th17 and Th1 are very important. They need to be, but if we don't control the infection first, that the inflammatory process will keep on going with the immunomodulation and immunodestruction, immunotoxicity. So it is important first to control the infection and then modulate the immunotoxicity and whatever. But if we do not treat them first with the antibiotics, then I think that the Th17 and Th1 will keep on occurring because of the infectious agent.
Right, I agree with you 100%.
So the infection has to be treated first.
Okay, and then to add exactly what Dr. Halasa said, because there was an article that I made reference to that I can send to you that talks about the fact that, okay, the initial infection probably is involving a biofilm, which is difficult to penetrate, which our bodies have a very difficult time penetrating, and that those nanoparticles loaded with methylene blue in concert with the right photodynamic therapy can penetrate those biofilms, or what this article was talking about, eradication of the biofilms. That would make
you're
fit.
right.
And okay,
you're absolutely right that but what you supply those treatments simultaneously. So you just don't go and give the antibiotics. You have to provide and prepare them with the probiotics, so that they are working. And as Dr. Ruggiero mentioned, that there are probiotics that those do have the effectiveness of busting the biofilm. And so that is number one. So you give that simultaneously. So it initially you are going to attack the free-floating organism. Then you are going to go after the cystic phase. And at the simultaneously, you are going to go after the biofilm busters. So that will get the large amount of organisms destroyed. And then you simultaneously follow with the treatment with peptides. And then you have to still use the glutathione, and you have to still use the antioxidant, and you can use the nano treatment, you can use the whole body laser, you can use the hyperbaric oxygen. They all have their role, but the step number one always amounts to that: prepare them with the probiotics and start the antibiotics.
Right, right. I think a combination, yes. So basically, you cannot just move the immune system to T and give them thymosin beta without taking care of the bacteria. So you need to give them antibiotics, Methylene Blue, maybe probiotics, all of this, which help to destroy the bacteria itself. At the same time, moving the immune system away from Th17, Th1, because you want to stop the demyelination and the multiple sclerosis that's being triggered by this bacteria, which is the Lyme disease. Now, the other thing that happened, we know that in naive T cells, they have the choice to become Tregs or become Th17. If you see, there's a common denominator, which is transforming growth factor. So which direction they're going to move, it depends on the level of interleukin 10 and 6. So if you have too much interleukin 6, then they're going to move to Th17. If you have too much of interleukin 10, then they're going to be moved to Tregs. In this case, with case of Dr. Patel patients, I believe because of this bacteria, I think you have too much of Th17, too much of interleukin 6. You will have even Tregs themselves can be transformed to Th17. And that's also another bad prognostic indicator of the disease getting worse. When your Tregs is becoming Th17, called X-Treg Th17, which is a hybrid of Tregs that's supposed to be suppressing the immune system, they are actually turn into or become Th17 and destroying the myelin sheath and causing the autoimmunity become more progressive.
Sometimes these patients have a high amount of TGF-beta. Sometimes they have as high as 10, 12,000, 17,000. So what do you make out of that?
But yeah, they have too much transform growth factor beta, but transforming growth factor beta is not all the way with Treg. They also activate to Th17. So here is about measuring the interleukin 6 and interleukin 10 ratio. And with this new lab, they can do that. You will see interleukin 6 is high. So which means that the transforming growth factor is actually in favor of polarizing to Th17 instead of Treg. So yes, you got my point here?
Yeah, but sometimes in cancer patients, we have seen very high TGF-beta.
Right. So that's another story. That's how the tumor is doing the same thing like COVID virus. It's trying to survive, right? So what they do, those tumors, they start secreting, especially the tumor microenvironments, they start secreting transforming growth factor beta, interleukin 10, interleukin 4, and possibly interleukin 6, and polarize the immune system away from Th1 so you can get less of cytotoxic T cells so you don't fight the cancer. And that's how the cancer is doing the same thing like COVID virus, is polarizing the immune system away from Th1. So this is in favor of the tumor growth. And that's why when you try to treat the tumor, you want to repolarize the immune system back to Th1 by finding the way to block those transforming growth factor along with interleukin 6 and trying to push it or give them interleukin 10 and try to push them to Th1. And you can use antibody blockades for that as well to block those cytokines. So if you have transforming growth factor beta antibody blockades, interleukin 6 blockades, interleukin 10 blockades, antibodies, that may help to move the immune system to Th1.
So you can give the TA1, but TA1 may not be sufficient. That's what you're saying?
I'm giving what, sorry?
You can give them the peptide TA1 if their TGF-beta is high.
You give them thymosin alpha for the cancer patients, yes.
So you would expect to see the TGF-beta going down, right?
It's supposedly, if you give them thymosin alpha, not beta, thymosin alpha, we are polarizing them. Yeah, so we suppose moving the immune system to Th1, and you need to give them interferon gamma, but there's a problem with interferon gamma. Yes, interferon gamma polarizes the immune system to Th1, but what's the problem with interferon gamma? They increase the expression of the PD-L1 receptor on the tumor cells, which will block the cytotoxic T cells. So you need to give interferon gamma along with PD-L1 antibody blockades. You have to give them together. Otherwise, if you just give them transforming growth factor, the tumor is smart. Okay, you're trying to polarize the immune system to Th1 and getting cytotoxic T cells, but here we go. I'm going to express the PD-L1 to block the cytotoxic T cells, and here we go. You're not doing anything. You got my point? So that's where this is a new field of immuno-oncology, which is very, it's recent development, and immuno-oncologists, they are very excited about those antibody blockades, and they are coming out in the YouTube and the TVs and in the media that they find an answer for treating cancer. The problem with those antibodies is when you give them, they have a lot of side effects because they don't go to the pathology itself. They go everywhere, and they can trigger autoimmune diseases. So the answer for that is to load them inside platelets, nanoparticles, and put them inside nanoparticles to get them as much as near to the cancer instead of going everywhere. But their success of using those antibody blockades. I'm not trying to say I'm encouraging adding into the profile, but I prefer delivering it as a nanomedicine. In fact, I am preferring delivering any injectable out there. Any injectable out there, you have thymosin alpha, vitamin C, whatever, and you want to get them into the tumor, it's better to be delivered through nanomedicine using the patient's platelets autologous to bypass the macrophages of the liver from taking them. Okay. So again, we saw that Tregs can become Th17 and multiple sclerosis. It's a bad thing, right? It makes things even more worse for the disease. Not all the time we think that Th17 is bad. We need Th17. We need neutrophilia because this is how you can kill the bad microbes that is populating into your gut. And also Th17 involved secreting interleukin-22, which is involved in formation of the tight junctions between the mucus. So you need to have active Th17. But overactive Th17, overactive interleukin-6 is not good, overactive neutrophilia, then it can cause destruction of the mucus and leaky gut syndrome. So you need an active, physiological active Th17 in the mucus, but not overactive. You don't want down activation of the Th17 in the mucus because you need it to fight the pathogens of the gut using neutrophils. And also you need to interleukin-22 to create the tight junctions, but overactive, it can break those mucous membrane, lead to leaky gut syndrome, and you have all the problem with leaky gut syndrome. When the guts are leaking toxins of the bacteria and free radical generators, what you expect to those multiple sclerosis, they're gonna get more worse, right? Because those are generating free radicals, leading to neurogliosis. And what would happen to neurogliosis? They start secreting all those free radicals, which will activate the sympathetic neurons and the pain fibers, and it can lead to sympathetic overactivity. Sympathetic overactivity leads to release of norepinephrine. Norepinephrine is a free radical generator. It stimulates the NOx enzymes in the mucus of the gut, and it leads to aggravation of the inflammation in the gut and lead more leaky gut syndrome. Leaky gut syndrome leads to more of free radical generators going to the brain, neurogliosis, sympathetic overactivities, more neuroproliferative in the gut, more sympathetic in the gut means more free radical generators, more inflammation. Then you have that vicious circle. So it's very important to stop this vicious circle by trying to break the cycle of the inflammation using all those methods that we just talked about. So let's talk about multiple sclerosis here. Multiple sclerosis is a chronic inflammatory disease involving destruction of myelin and central nervous system white matter. So it is an upper neuron disease. Upper neuron, it involves both sensory and motor, but it's upper, not more lower. Like Guillain-Barré syndrome, it's a lower demyelination. This is upper, means that the brain and the spinal cord, they are demyelinated, sensory and motor. So this disease presenting patient has deficient sensory and motor function. You will have unilateral vision loss, diplopia, gait disturbance. Yeah, you need to have that fast conduction, which myelin sheath is providing, to able to sense your arm where they are, so you can have the right motor response, so you can walk or you can move without having that fast integration of the motor and sensory, knowing the position of your hands. Then you will be unable to move your hands properly, and the patient starts falling, and so we will have problems with the bladder. Yes, they will have loss of bladder control, among other vague symptoms of nervous system malfunction that we know. In multiple sclerosis patients, myelin reactive T cells not only secrete interleukin-7, so we know that it's not anymore Th1 dominant, it's also Th17 dominant, so you will have a lot of interleukin-6 there, interleukin-12, and you will have cytotoxic T cells destroying those myelin sheaths, and you have neutrophilia as well. In addition to too much of those cytokines, such as interferon gamma, can turn those Th17 into Th1, in a hybrid called XTH17 Th1, and also they can turn the Tregs into Th17, and that's even more worse, those hybrids. And then, so yes, so if you go and you measure the cerebrospinal fluid, you will find out that the interleukin-7 is high, along with other cytokines and cytokine interleukin-12. So both interleukin-12 and 17 is going to be high and responsible for pathogenesis of multiple sclerosis. And we learned that in the hard way when we give those patients antibody blockades against interferon gamma receptors. We find out the patient is flaring up, and that's because you unblock the Th17 even more, and you would have Th17 overactive and neutrophilia and damaging. So if you, in order to manage multiple sclerosis, you need to give them both blockades, interleukin-17 antibody blockade and interleukin-12 blockade. So you have to give them both. You don't give them one. And also you need to give them all those repurposing drugs that we talked about. Maybe Methylene Blue, which buffer detox and restore the balance of the immune system. Yeah. What else do you want to give them? Don't give them ivermectin, because now we know ivermectin moves into immune system to Th1. In those cases, we can give them thymosin beta, yes, to move them away from. We're doing things that's different from opposite to what's giving to COVID. In certain way, not everything, because polyphenols does restore the balance, not shifting to any direct. In other words, they help to restore it. So if you have too much of Th1, moves it to Th2. If you have too much Th2, moves it to Th1. So that's the polyphenol, along with Methylene Blue, does that same thing. I will give naltrexone low dose, yes, because we know when experience that it does have to shift the immune system from Th1 to Th2. Okay, so giving flavonoids, yes, polyphenols. I will not give ivermectin, although it's written here. That's kind of a mistake, but I will do, so those are things that we don't want. I don't think I would give losartan as well in those patients because we know losartan moves the immune system to Th1. But I will give Methylene Blue and polyphenols and flavonoids and antibody blockades. And I will do everything to buffer the redox. I will block the NMDA receptors as well using B12. I will give CBD for those patients. Yes, resveratrol. I will make sure we manage the leaky gut syndrome by giving them prebiotics and probiotics. We learned that there's a very great probiotics that we learned from the lecture of last night about those probiotics that resist the 5G and electromagnetic. So hopefully we're going to bring the doctor in Osteopathic Society here to present. I like that special probiotics which resist and the 5G and electromagnetic waves, and also it offer or it transfect your biomes itself to become resistant to 5G, so they can survive in 5G and function in 5G, which is a good thing because you don't want to have a microbiome that can be killed by the 5Gs and by non-ionized radiation. So if you have a microbiome in your gut that resists that and can survive that, that would be great. And if they can also certain way through viral, what we call it, bacteriophages, according to the lecture of last night, that they can also transfect your own body cells and deliver them the genes of those bacteria that express antioxidant enzymes and that will scavenging the free radicals. That will be another good thing to protect yourself from the non-ionized radiation. So the other thing is we need to also consider all the holistic things that we are doing, like, no low carb is very important because too much of sugar, the sugar can become free radical generators, glycans. You don't want that because that will generate free radicals, aggravate inflammation. So low sugar diet, low salt diet. That's another thing. That's very interesting, right? Why low salt diet? Because they say the salt kills your good bugs of your gut and it can lead to leaky gut syndrome. This is one way the salt is not good for the good bugs of for the good microbiome of your gut because it kills it, okay? So this is one. And then your pathogens or the bad bugs will populate and breaks those membrane, in other words, those barriers of your gut and lead to leaky gut syndrome. So low salt diet is it's a good advice for those patients. Another thing about salt, so when you have too much of salt, what would happen to the level of aldosterone? It will decrease, right? But if you have less salt, low salt diet, you would have aldosterone is high. And aldosterone is proven that it helps to block the Th17. Oh, that's good, right? So aldosterone, it helps to block the Th17. It helps to block interleukin-6 signaling. So that means decrease the inflammation. So if I take, or I recommend low diet salt, that's mean I will have enough of aldosterone. That's mean I can block from inside our body, we can block the Th17, interleukin-6, and decrease the inflammation. That's a good thing, right? Okay. Again, about this vicious circle where you have toxins released from the guts. They irritate the neuroglia. They start secreting inflammatory signaling and activating the pain fibers and the sympathetic fibers. And then you have sympathetic overactivities, right, going through the vagus nerve. And the sympathetic release norepinephrine in the guts, stimulate the NOx enzyme, generate free radicals, aggravate the Th17 in the gut, makes it overactive, and interleukin-6 and neutrophilia. Too much can breaks down the barrier, leading to leaky gut syndrome again, neurogliosis, and you have this vicious circle, which you need to break it with the recommended treatment that we talked about, and also giving them probiotics that will be inhibiting the bad bugs like segmented filamentous bacteria and SFB. Okay, so giving probiotics is good, especially the probiotic that resist the EMG, the electromagnetics that we learned from last night. That would be nice if we can give those patients. And also low salt, low sugar, and fixing all the metabolic panels. If there's any errors, like if you have low 6 hormones, if you have, you start checking all those metabolic panels, and if you have low vitamin D, you need to give that patient. So you need to look at any problems with the metabolic panels, especially the 6 hormone, the vitamin D, and all others, and then you start fixing them and providing the patient with nutrition to replenish that. If you see also low cortisol, you need to work on that as well, especially those patients, they're being depleted from the cortisol because they are being overactive for nothing. And their neurotransmitters is being exhausted and depleted. So you need to give them all those neurotransmitters that helps to replenish the neuronal hormonal axis, and of course the thyroids and the sex hormones and the cortisol needs to be normalized by doing that. And so if you see a patient has a problem with conversion of T4, T3 because of multiple sclerosis, and they have microcytic anemia, but their transferrin is percentage saturation is high and the ferritin is high, don't try to give them iron. Or try to give them T3, you need to fix the inflammation. And if you fix the inflammation, you will restore the conversion of T4 to T3. And if you fix the inflammation, you decrease the hepcidin, which prevents the absorption of iron. So when you give them iron, they can absorb it. Because if you give T3 to those patients, oh, well, T3 is low, let's give them T3. Oh, they have iron deficiencies, they give them iron. Iron and T3 can generate more free radicals. The T3 can activate symbiotics and leading more symbiotic activities and generate more free radicals and causing more problems. If you give them iron it can be oxidized in this inflammatory millennium and it can cause ferrics, and this is a free radical generators and they can cause more inflammation. So I will not give iron or T3 for those patients. I will be focusing on restoring the metabolic balance, restoring the immune balance, restoring the redox balance, and I will use nanoparticles to target all those drugs, especially the injectable ones, into the pathology. That's what I will do. I think this will be the part 1 CDPMCS lecture. We will be doing the COVID virus pathophysiology management maybe next time because I took a lot of time. So go ahead if you have any question, Dr. Bill, the mic is yours. Are you sleeping, guys? I got disconnected.
We're still here.
Oh, okay. I thought I made people sleep here, and I'm trying to make it where they can ask me at any question, at any time, interrupt me. That's fine. I need that interruptions because I need the chain of the thoughts to be continued, and I don't want audience to be sleeping. So if you have any questions, please ask.
I was just going to make a comment, Dr. Halassa, about the leaky gut. By the way, that was fantastic. I mean, every time I'm learning, I mean, we're in the same group, but then I go to this group and I'm listening to your lecture and suddenly new questions are popping up and opening up a better understanding. Something went through my mind when we were talking about, say, if you had leaky gut or bacterial overgrowth or dysbiosis that is breaking down the tight junctions, and that the Th17 shift, those cells, those Th17 cells are releasing interleukin 22, which is helping to stabilize the tight junction. So it's not like you want to immediately shift or repolarize the immune system. But what went through my mind is, I'm curious to search the literature to see, because we had mentioned before this idea of using the loaded nanoparticles to reduce the biofilms or to break through some of the biofilms. And so perhaps there's some literature out there actually showing evidence that loaded nanoparticles can help to reduce the dysbiosis that will slow down that process so that we can get that under control, and then we can help to repolarize the immune system, because that Th17 shift is probably also triggering other problems like maybe an autoimmune disease or even like a seronegative rheumatoid arthritis.
Joseph.
Right. So when you have inflammation in the brain, you would have inflammation in the gut. And the reason, because inflammation in the brain activates the sympathetic, and the sympathetic start releasing those norepinephrine and generating those free radicals, which will trigger and overactivate the Th17 in the gut, where it's not unnecessary, and leads to the breakage of the gut epithelium. This has happened to the same people who are having traumatic brain injury, and then they have leaky gut, right? And initiated by the brain injury, causing neurogliosis. Neurogliosis causes activation of the pain fibers and also activation of the sympathetics, and the sympathetic release norepinephrine in the gut, which will aggravate the inflammation, making Th17 overactive, which instead of protecting, they start destroying and causing the leaky gut. So that's one way of mechanism. Now, yes, you need to work on restoring the balance first and decrease the inflammation, and restore the normal physiological response of Th17, which is a healthy one, that actually build the mucous barrier and the tight junction that we need. So you need to give the treatment to restore that and break that suspicious cycle of the neurogliosis and leaky gut syndrome. You need to work on that. But at the same time, if there is also a problem with the microbiome itself, and you have too much of pathogens, or the microbiome is unhealthy, then you need to work on that aspect as well. Now, we thought when we give low dose of methylene blue, it will damage the microbiome and the healthy and the bad ones. But according to the recent publication, we find out that's not the case. In low dose methylene blue, it only destroys the pathogens. It does not destroy the good bugs of the gut. So that's something great. And I think I shared that article with you as well. So methylene blue works like a prebiotics in this case, with low dose. Not talking about high dose, but with low dose, it works like prebiotics. And they gave it to the patients, methylene blue with the traumatic brain injury, TBI, and it prevents the shifting of the gut microbiome from becoming pathogens. And that's something you can investigate more about.
What is the low dose methylene blue?
Yeah, I think the one that's being studied, again, is Alzheimer by a big pharma company for Alzheimer. They use 10 milligram and 100 milligram. They find there's not much difference. So I will stick with 10 milligram daily.
Because I have a chronically ill, and they cannot tolerate 10 milligram dose.
Then you just go ahead, lower it, but you need to find out why they cannot tolerate it. They may have the the glucose 6-phosphate dehydrogenase deficiency, severe one.
I'm sorry,
so
what?
Just go with 5, maybe.
What deficiency you say?
The 5 dehydrogenase, glucose dehydrogenase 6.
G6PD you are talking about? G6PD?
Yes.
Okay.
Uh-huh.
Okay.
Those patients.
I have a question for Dr. Joseph. Yes. You mentioned about that nano technique and giving that to treat the infection and dysbiosis. So you give, what is the route of treatment?
Yeah, great question. I have patients that know me for many years, and they want to try new things, and I also try new things on myself. So I very conservatively have given IVs with the filtered particles loaded with a very low dose of methylene blue. And, just from this is maybe a non-scientific answer here, it seems that methylene blue is like an equalizer. From the study that I read that Dr. Halassa had sent, which was really good, talking about low dose versus high dose. The high doses seem extremely high, and I cannot even imagine going as high as it takes to become toxic or causing killing off the good bacteria. I do have experience with methylene blue as far as myself, and when I first took it, it was the first time the fact that I had symptoms like flu-like symptoms the first day, it could be because I had enough pathology in my body that it was triggering a good reaction to help my body. I'm not saying right. I wish I could say it better.
You had a heart reaction.
My body was reacting in a way, it was almost as if I had pathology that needed to be addressed, and that the methylene blue was triggering an immune response to the pathology, and then that cleared up. And then as I continued to take the methylene blue, and it was ironic because my urine started off clear when I would take the methylene blue, meaning that it was obviously shifted to leukomethylene blue, meaning it was reacting naturally with something that needed to be buffered. And then as I continued to take it, my urine started to turn blue, meaning that whatever overabundance of pathogens I had, my body may have gotten into balance, and that the methylene blue was no longer being oxidized. I believe that would be the correct way to say oxidized. And so I had reached a homeostasis. But yeah, even if I try to go up to 10 milligrams, it's like I have to build myself up. And I've even heard from naturopathic physicians that there's like a methylene blue challenge where you build yourself up slowly, because the more pathology you have, the more the methylene blue is going to be oxidized, the more you're going to have an immune response against an abundance of pathogens, that you're walking around with every day.
Can I interrupt you here
yes.
for a minute? What dose of IV methylene blue did you use?
I used, I started off doing almost like drops of the liquid methylene blue that we had originally through Dr. Bomer, that we used as like a mouth swish, where I would only swallow maybe almost like using a dropper and putting a couple drops under my tongue and then swallowing it. And then I built myself up to a half a teaspoon.
Right.
And then when I did a teaspoon is when I felt like I was developing flu-like symptoms, but then it was gone the next day. And it sounded like that was normal based on a conversation I saw actually on YouTube that got deleted right at the beginning of the pandemic.
Oh, thank you. What about the IV? What dose did you use IV?
I actually went with a very high dose IV originally. I believe I did 10 milligrams, the whole bottle of methylene blue in 500 cc's of normal saline. And this was after I had been taking methylene blue, at least a teaspoon, a half a teaspoon, for many months, maybe 6 to 8 months. So my body was already sort of recalibrating, getting into a balance. That's the way I see it. And then I did a large dose of the methylene blue and I discussed it. And that was maybe pushing the boundaries, but still far less than the doses that they're talking about that have a negative effect. It seemed like they were in the hundreds of milligrams.
What symptoms improved?
With the methylene blue, with the IV?
Yeah, with IV first, and then the oral, you probably had GI symptoms, whatever. But
that's exactly what I had when I first started doing the methylene blue. I had almost like esophagitis, and then I had a lot of GERD type symptoms, bloating type symptoms, and I was not at my finest as far as my health. I have to admit I was not doing anything special, especially on lockdown. And so I was having bloating, I was gaining weight, and the methylene blue just enhanced it. It was almost like a wake up call. But eventually the sort of GERD type symptoms eventually resolved. And, you know, methylene blue, it's not like and I would do the red light. I have a red light mat that I do. And all I can say is I really notice a difference in general when I wasn't feeling good or I thought I was coming down with something. If I took methylene blue and then laid on a red light mat, I felt back to normal almost immediately after that. But I never did take methylene blue and suddenly feel like, wow, I feel amazing.
What about your patients? You used on your patients. So what did you said initially you started using on your patients that they wanted something new and different.
Yes, great question. I had a patient who has, you know, type 2 diabetes. He has restless leg syndrome, neuropathy, obesity. Pays no attention to his diet. He drinks Coca-Cola every day, eats Southern food. He's from the South. And he took 1 5 milligram capsule of methylene blue and it basically became nauseous and said he was vomiting and thought that it was more of just a side effect, a bad side effect from a drug. And I suggested that, you know, I think you have enough inflammation and oxidative stress and this being probably naturally the bacterial overgrowth in your gut that we would probably have to do like the methylene blue challenge where we start off with this, just a drop, you know, 1 drop under the tongue and build yourself up. I've also treated a COVID patient that was a 70-year-old male who had severe COVID and was trying not to go to the hospital and was desaturating, but was stable, but not doing so well. And I gave him IV methylene blue. It was 1 milligram along with I think 1,500 milligrams of vitamin C. And I also gave him thymosin alpha push. And he actually immediately was better. He went from laying on the couch to standing up in the kitchen and carrying like a normal conversation. A few days later, he did start to desaturate again, went to the hospital because he was having a decrease in his mental status was getting questionable. His wife was just, no, and I said, yeah, absolutely, it's time. But the hospital said he did better. They didn't know what he did. They just said he had a blue tongue. And he said, but he did better than everybody else on the floor. He survived and was one of the few survivors. That says something, okay? And I presented that case partially. So I have a lot of people who I've taken methylene blue. It was just that one patient who had a mountain of medical problems, and then it made him sick to his stomach. And that's the worst that it ever was, which tells me that if you have a lot of pathology, you may want to start with a lower dose. Even if I try to jump from 5 milligrams to 10 milligrams, I can feel it, you know? And what I feel is like, I don't necessarily feel better. I feel maybe slightly worse, which tells me again, that maybe perhaps I'm getting to another level of homeostasis, but 10 milligrams is so far below the milligrams that they're talking about that caused a problem with killing the good bacteria. I mean, we're talking in the 100 or hundreds of milligrams of methylene blue. I mean, I wish I had that article in front of me, but we're talking like 10 milligrams per kilogram. So if somebody weighs even 60 kilograms, then we're talking like 600 milligrams of methylene blue. We're not even not even in the ballpark whatsoever with 5 or 10 milligrams. If anything, we would have to go probably start even lower for somebody who has a lot of chronic pathology.
Well, thanks a lot for your input. So, Dr. Halasa.
I hope that was helpful.
Oh, it was wonderful. I think it will guide many people sometime in dosing. You know, if a patient complains of, you just stop it and then just say, we are going to stop a drop by drop dose. So there are many different ways you can treat. But we have used in a nano way, the antibiotics and methylene blue and TA1, and patient has responded very well. So there are many different ways you can treat it. Once you master one molecule, another molecule, then you can mix, and the nanofication, sonication, and entrapment does really work to treat the chronically ill patients, those who are not responding to the treatment.
Yeah, so what do you think, Dr. James? Do you think Dr. Patel is INTP? She's logician with all her asking and connecting the dots? No, that's very logic, right?
Well, it is. It's more like a ENTJ. That's more extroverted thinking, because she demands to see the data first, and she's asking very good questions. So she reaches out for the information. The INTPs and introverted thinkers like us, Dr. Halasa, we operate more on logic. If something is logic, this equals this, then if this, then that, and if that and this, then that, and you cannot argue that. But for myself, I know I've had to then, okay, but then I need to, where I have to validate it with at least something translational to back it up. So it's just not my thinking. So that's my first instinct. But ENTJs are natural detectives, and they come off a little more skeptical, but that's what makes us work so well together, because she pushes me to validate what I'm thinking to be true. And usually I'm not far off, but she's right. And I actually agree with her
I do appreciate her, because that's what we need. We need somebody to really help us to verify and negate and criticize in the way that we can rectify things. So this is called interactive learning. And I wish all the audience here will be following up with questions, asking questions.
We have a few.
Because we learn from questions more than we learn from passive learning.
We have a few questions, Dr. Halasa.
Okay.
Okay. What is the brand of probiotic, and where are the nanoparticle medicines available?
Well, the brand of probiotics, yesterday we have Dr. Mark Ruggiero, and he presents a very wonderful probiotic, a very unique one. They took the bugs from the wild, somewhere from the from areas where they resist ionized radiation, and they can survive non-ionized radiation, which is 5G and electromagnetic waves. So they have a certain strain of bacteria that they are able to survive those harsh environments of electromagnetic and also ionized radiation. And then they culture it with our normal microbiome and bacteria, which is lactobacillus. And it happened that the genetic material of this wild bacteria was transferred by transfection, which is bacteriophages, viruses, to those microbiome of our guts. And it conferred the antioxidant capacity those genetics are expressing to combat the effect of the killing effect of the electromagnetic waves in 5G. So I want to have Dr. Mark Ruggiero to present his unique micro probiotics that resist 5G, and I think you as a DOs, you like those kind of 5Gs and electromagnetic resistant microbiome. And in a certain way, it compare our body cells also with the same genetic material that express antioxidant to buffer the redox. And also they provide, or they express protein that absorb this harmful energy and transform it into less harmful form of energy. There's certain protein that they express, what is kind of photosensitive or possibly electromagnetic sensitive, and they transform it into less damaging form of energy. So I like that, the presentation. I wish Dr. Mark will be scheduled here. I think we have somebody here.
You get me his
representative.
Get me his contact and we will get him.
Yeah, Presidium, is he there?
Hi, yes, this is Jamie. I'm sorry I don't have video capability on this device that I'm on right now. But yes, Dr. Ruggiero did present yesterday, and our website, www.presidium.life, has a range of information, but Dr. Ruggiero is very happy to present his scientific presentation.
Yeah, so can you schedule, can you share, can you connect with Dr. William? I gave you a cell phone number. Reach out to him so you can put him on the list. When do you think Dr. William will be a good time for him?
We have a couple of already scheduled. It'll probably be towards the end of November. I can give you an exact date. Okay?
Great. Now, the other questions about nanomedicine. I think we have the group already doing it. There are 10 clinics in the United States, one in Germany, another one in Bahamas. And they're taking platelets from the patient and they are mixing it with any injectable drug, let's say thymosin alpha, cortisone, antibiotic, cancer drug, antibodies. And then they mix it through sonication. So you break those platelets and you load them inside those platelets exosomes. And then we do nanofiltration through passing those fluid through a filter. It's called extrusion process. That's how you make liposomal vitamin C. It's extrusion back and forth. And then you get all the nanoparticles that has a size less than 200 nanometer loaded with the injectable that you're giving. And then you go ahead and you provide it to the patient. So this is the simplest way of doing nanomedicine at the clinic. The company who is doing the same process, they adding PLGA in the middle to stabilize the nanovesicles or the vesicles that they produce from the platelets, make it more stable so they can last longer in the shelf. But us as a clinician, we don't care about it because we're not selling that drug. So, and it's more simple. You don't want any extra drugs to be involved, make it more natural. So we skip that process and we just do platelets, loading it with the drugs directly using sonication, nanofiltration, extrusion process. But I can definitely help you to develop that in your clinic.
I forgot to mention the wins. I was on the spot and I couldn't think immediately of all the positive and sometimes heroic times I've had with the platelet-derived nanoparticles, methylene blue. And I had a patient, 33 years old, diffuse thrombosis, dilated cardiomyopathy with COVID, got out the ICU. He had a ejection fraction of 15%, and this was about 6 months ago. I treated him once, I treated him again with loaded nanoparticles, methylene blue, and a deeper penetrating red light directed towards the heart. His ejection fraction is now 48%. And this is after he was told he would probably need some sort of a partial mechanical heart transplant. I've also had great success. I would say the methylene blue, the loaded nanoparticles, even loaded placental-derived exosomes, when I would give IVs, say for autoimmune disease, especially if somebody I had a patient who had severe multiple autoimmune disease and severe gut dysbiosis. And this combination IV, I can tell it enhanced the IV treatment. I got a better result than if I would have just given the placental-derived exosomes by themselves. Again, these are private patients. I do not advertise. They ask me for this, and they understand this is experimental. Methylene blue, it gives impeccable breath, by the way, impeccable.
Oh, I got disconnected there.
Okay,
Okay,
so
any other questions?
what's the dose of IV methylene blue?
You start with 10 milligram, but if the patient is having cancer, you can go up to 50 milligram. I will not do above 50 milligram, just for, so this is like the recommended doses by FDA is 0.5 milligram per kg to 2 milligram per kg. This is what we're giving it to patients with methemoglobinemia, FDA approved for that application. For Alzheimer, according to the company who's doing it, they're doing 10 milligram capsule a day. But in the COVID-19, if you're a patient with ICU, you can go up to 50 milligram. I did it for 25 milligram for the patients, and you can see their oxygen saturation goes from 60 to 90. And there is big publications for that support what I experienced with patients overseas. That I have some influence over changing the protocols that they're doing. So you will see miracles with COVID-19, and there's a lot of publications around. Ivermectin publication with COVID, if you go to PubMed, is 200, but not all of them in the side of good of ivermectin. Some studies, they are against it, but 50 a publication for methylene blue with COVID, and all of them are positive, 50 publications. There is 20,000 publications of methylene blue against viruses in general. So if you do COVID, you do viral methylene blue virus, methylene blue PubMed, and search it, you will find 20,000 articles. Ivermectin is 8,000 article regarding ivermectin with virus. So methylene blue has more publications, more safer than, and the other thing about methylene blue versus ivermectin, they do the same thing. They block the spike receptor. They block interleukin 6 and Th17 the same way. The extra thing that does the methylene blue that ivermectin does not do is that methylene blue buffer the redox to help to reduce the ferric to ferrous, which you needed in cytokine storm. And also methylene blue helps to increase the blood pressure. When blood pressure drops at the end of the cytokine storm, you have too much inflammation all over, and they will end up with vasoplesic shock. So you need to increase that. And the methylene blue does help the oxygenation of the mitochondria by bypassing the blockage that's happening because of the nitric oxide or because of the peroxynitrates. Those mitochondria gets blocked, so they can bypass that block, energize those mitochondria. And ivermectin does not penetrate the brain. So if you have brain that's been infected with COVID virus, which they do, they infect it to the point where you don't sense the oxygen level. Methylene blue does penetrate the blood-brain barrier, and it does help to neutralize those viruses by binding to their spike receptors and inhibiting their pathological effects on the cells. Any questions?
Okay. Where can you get methylene blue and also Thymosa alpha?
Well, I'm working with, everybody knows Mike Beamer, the pharmacist. I work with them, and we develop now intranasal thymosin alpha and beta. So the pharmacist does have it, but you can check other pharmacists as well. They may have it as well. But I know Amex has it. They also have methylene blue, and they have ivermectin, and they have many things.
Yeah, that's where I've gotten it too, and we get less hassles from Mike than any other place, really. So,
right. At least he's a good guy. I like his personality, and he's very innovative, and he has that lovely personality that you can work with. Okay. Any other questions?
no more on the chat here. I just have a couple of things, other things for us. So we made it through the OMED, which is, the AOA Scientific Convention, and spell the name of the pharmacy, AMEX. Amex Pharmacy.
Amex Pharmacy, yes, AMEX.
Okay, and I guess the only one here is Dr. Burgess. So we'll discuss the issues with that. So March 25th to 27th is the last weekend in March 2022. We will be at the Flamingo Hotel. We have a great rate, hotel rate, like $45 for Thursday and $100 for Friday and $120 for Saturday. And if you've been to a hotel lately, you know that that's like half of what most hotels are going for, especially for being on the Strip. And so we're putting our program together. If anybody's interested in speaking, our big four topics are hormone replacement, cannabis, anything Dr. Halassa is interested in, and practice management and rheumatology. So that's 5. But anybody has any topics they want to present, please let me know. You have my contact information. And we're looking forward. It'll be a hybrid. So if you don't want to travel, we'll be able to do it online also. And I'm looking forward to it. OMID, we were supposed to be in Phoenix this last weekend and they kind of chickened out. So, and I much prefer being in person. I personally will be at the Age Management Medical Group next weekend, first weekend in November. It is at the 4th to the 7th. And that's in Dallas, agemed.org, agemed.org. I can type it in here if you're interested. They have a lot of they have a lot of interesting speakers. A lot of the folks we've had on here. It's where I learned about traumatic brain injury and hormone issues. Was from those folks, and they're very friendly. I like them a lot better really than A4M. Not that I don't like A4M, but Age Med is a little bit smaller group, and we have a really nice time with them. So. So anybody have any questions? Next week, we have Dr. David Lefkowitz, who is from Chicago. He does our pain management lectures. By the way, our symposium always have 2 hours of pain management, 1 hour of suicide prevention, which are a lot of the state requirements for licensing. So we always make sure we have those. So you come to us and you're good for anywhere from 1 to 2 years, as far as whatever that's Nevada, California, and I think a couple of the other states, Arizona also mandate those. So so you get those with us, and that's about it. If you have a friend, please bring a friend. Thank you, our regulars here. Thank you very much. And we have some newcomers. Shel Stein is a new name. Estelle is a new name. And there was a couple others earlier. Anybody else have any other questions, comments, complaints? Let's see. Yes, sorry, there were 2 people out in the waiting room. And sorry, 2 of you that were out in the waiting room. Sorry, I was talking, so I wasn't watching. So Anna Fishbein, welcome. We've not seen you before, so thank you for coming. Please don't be a stranger. If you have something that you'd like to present, we're always looking for presenters. If you have, and please bring a friend. And Farid is, I think that's a new name. I'm not sure. Anybody else have any questions, comments? Otherwise, we'll say good night. Like I said, next week, Dr. David Lefkowitz, he does medication-assisted addiction therapy.
And by the way, sorry, my phone disconnected, so I was unable to give the whole story. But I would love to come back and give more detailed presentations, you know, based on my experiences, case study with the methylene blue and the platelet derived nanoparticles, because
we're on the list, Dr. Joseph. We're on the list.
All right, because this is very, very powerful you know, I think this will help us to get to the next level with all the other things that we're getting to the next level on.
Okay. All right, you're on the list.
He's part of the family. He's osteopathic doctor.
I know. You only have to mention once. We don't ask twice. We don't ask twice. We'll grab this. Okay.
All right.
So okay. Thank you all.
All right.
Okay.
Take care. Good night, everybody.
Okay,
Good
John.
night.
All right.
Anything to add, John?
No, OMED was total success, so no complaints.
Well, yeah, I don't know. You know, the first lecture I listened to was from at OBGYN, and you know they made we had to drop out Dustin and Kent for because they own companies, and the first person in OBGYN sells courses on you know, on OBGYN stuff. So I don't understand, you know, why that was okay and ours weren't.
Yeah, well, we were nice boys and kept our mouths shut, so it worked out great.
Yeah, so yeah, you know, they tried to throw us out more than once. So
yeah, we know what's going on. So, but it all went well.
Okay, all right. So thank you to everybody. Thank you for you know, being here, and hopefully we'll see you again next week. Don't be a stranger. If we don't have your email address, please get it to us somehow. You got mine there, doctrbil9@gmail. Okay, we'll say goodnight. We'll have this tape up in probably 2 to 3 days. We'll have it on our website. So talk to everybody next time. Thank you, Dr. Alasa.
Bye.
Thank you, Dr. Alasa. Good to have you back.
Okay, bye.
Yep.